receiving neuraxial anesthesia become hypothermic like in those having general anesthesia, but to a lesser degree. So if this is general anesthesia, you can see this one, the red line. It's similar to the line of the general anesthesia, except it's a less degree. So vasoconstriction and shivering thresholds are reduced, but to a lesser degree than GA, as I just said. And hypothermia causes less discomfort because patients do not have the feeling of cold. So this is probably due to the tonic cold signals that are blocked due to our neuraxial anesthetics, and the patient will have a constant feeling of warmth. Okay, for combined general and neuraxial anesthesia, so they have the highest risk of becoming hypothermic, due to the additive effects of both the neuraxial and the general anesthetic. As you can see, the blue line. Okay. And vasoconstriction is definitely impaired because of the additive effects, as I said. As you can see, instead of having a plateau for the third phase, it continuously drops because there is more vasoconstriction when the patient has a combined anesthetic technique. So for peripheral nerve blocks do not have any clinically thermoregulatory effect on patients. I didn't say that correct. They do not have a clinical important thermoregulatory effect on patients. So peripheral nerve blocks only prevent local neurally mediated thermoregulatory responses, which can be compensated by for the other parts of the body. Okay, so now we'll go to what my lecture is really supposed to be on monitoring. So normothermia should be maintained during anesthesia and surgery, and temperature disturbances can only be detected by continuous temperature monitoring. So the following societies have the following statements on temperature monitoring. So it is important to note that none of them actually state that temperature monitoring alone is essential or mandatory for all cases. So when do we have to monitor temperature? Summarizing what I just showed you kanina, patients who are, we monitor temperature in patients having general anesthesia for more than 30 minutes, in patients undergoing major surgery with neuraxial anesthesia, and in suspected cases of intended, anticipated, or suspected temperature change. Temperature monitoring is not necessary during mild or moderate sedation and peripheral nerve block. So it is necessary for patients who will be undergoing cardiopulmonary bypass, for cases that are expected to be of MH, and for expected cases of hypothermia, like in the geriatric and pediatric age group, and as well as the burn patients. Okay. So there are a lot of sites for monitoring. They all have different accessibilities. They also have different accuracies. Okay, so it's not very clear, but I'll be discussing them later. So the core temperature is the best measure for temperature. Although it is no means completely characterizing the whole temperature of the body, it is the best single indicator of thermal status in humans. So the skin temperature varies markedly as a function of environmental exposure. That's why skin temperature is not very useful for us during anesthesia. So we'll first discuss pulmonary artery thermodilution. It is the best measure for core body temperature and is actually considered the gold standard for measurement. So this along with cerebral thermometry, but I won't discuss cerebral thermometry because we don't put that. The neurosurgeons put that, or the neurocritical care specialists put that. So pulmonary artery thermometry requires technical ability to insert and is usually inserted with a central catheter. The esophageal thermometry using a distal esophagus thermocouple is also a definitive standard. It should be inserted properly because there is a temperature gradient within the esophagus. So the probes that are inserted too far down will reflect lower temperatures due to temperature of the gases. So the practice is to insert it within 40 centimeters from the corner of your mouth, okay? Or at the point of maximal heart sounds. So the esophageal thermometer is usually attached to an esophageal stethoscope, which we use for pediatric cases. The tympanic membrane thermometry is an acceptable approximation of core body temperature. Insertion is a little difficult and must be done under direct visualization, and the probe has to be occluded after insertion. So this thermocoupling is a more accurate form of tympanic membrane thermometry rather than using the infrared scanners. Nasopharyngeal thermocoupling is also an acceptable form of core body temperature monitoring. The probe is inserted 10 to 20 centimeters from the nares. Though the probe is thinner than your usual nasogastric tube, it can still cause damage to the nasopharynx, so you just have to be careful when inserting it. So the multi-use thermometer, which may be used for oral, rectal, and bladder thermometries, measure near core temperature. So it doesn't measure core temperature, it's just an approximation. No? They are adequate for monitoring, but they are prone to misinterpretation. So for example, oral temperatures are inaccurate when breathing is through the mouth or through an endotracheal tube. For rectal thermometry, there is a thermal delay in the sensing of the temperature. And for bladder temperature is very influenced by urine flow. So if you have poor urine flow, the temperatures will not be reflected correctly. So skin surface thermometry is the easiest and most accessible form of temperature monitoring, but it varies markedly as a function of environmental exposure. So this form of thermometry is most acceptable for our patients who are under mild moderate sedation, under neuraxial anesthesia, or those who are having peripheral nerve blocks. So the nearest to accurate skin surface thermometry is the axillary skin thermometry. So how to do it? You put a thermocouple on the axillary artery and adduct the arm to make sure that it's near to core temperature. So the temporal artery and forehead thermometry using an infrared scanner is actually not accurate. There is usually a 2 degrees Celsius difference from core temperature, but some institutions still use it rather than not having temperature monitoring. So this form of temperature monitoring may be used just be sure that you compensate with the 2 degrees Celsius. So let's go to the management. So the National Institute for Clinical Excellence stated this. So that the least invasive modality that gives a reasonably reliable assessment of core temperature should be used depending on the site and devices available, as well as the physician competency. So in short, the NICE is just telling us that we should monitor it with whatever we have and with whatever we can use. So this is the recommended measurement time. Okay, and the goal is to maintain normothermia or core body temperatures between 36 to 37.5 degrees Celsius. So again, I'll just flash this slide so that you remember when it's mandatory to measure temperature for our patients. So temperature fluctuations can be minimized and managed by a variety of ways. So hypothermia in the preoperative period is prevented by, number one, ensuring a warm operating room temperature, insulating the patient, and by instituting cutaneous warming, either by forced air warmer or by a drop light if it's allowed in your institution. So intraoperatively, cutaneous warming can still be continued, and invasive warming may be necessary. So there. In the post-operative period, cutaneous warming should still be continued, while pharmacologic management may be necessary for our patients who are shivering. So a recent study in 2016 showed that warmed IV fluids and forced air warming showed marginal results or no efficacy in avoiding hypothermia. So this study is not saying that we shouldn't institute these methods. No? It's just saying that alone, either of these alone will not bring our patients back to core body temperature of normal. Another study done in 2015 showed that even with active warming, redistribution hypothermia will occur. So what can we actually do for our patients to prevent hypothermia? So these questions are answered by this study, which showed that Pre-warming in the holding area for at least 1 hour before induction reduces redistribution hypothermia and prevents hypothermia intraoperatively and postoperatively. So if there's anything that I want all of you to take away from my lecture is that pre-operative warming has a very, very important benefit for our patients. So it's not just intraoperative and postoperative warming. As soon as our patients enter the holding area before surgery, we should start instituting warming techniques. So this figure compares core and peripheral temperature. This is without pre